Welcome back to our discussion on the reproductive system. In this chapter, we're going to talk mostly about the female reproductive system. Now, when we get started here, the male and female reproductive systems do share some similarities. For instance, both systems produce sex hormones, gametes, and both have series of ducts that move their gametes. But when we focus on the female reproductive system, it also has to support a developing conceptus, the offspring, from fertilization through birth. It also has to nourish the infant, and so these functional differences will lead to structural differences. And when we look at the anatomy here, the female internal genitalia include the ovaries, the uterine tubes, the uterus, and the vagina. And we're going to look here at a mid-sagittal view. And we're also going to see two pouches created by the peritoneum as it dips on either side of the of the uterus. And there's a pouch between the uterus and the bladder, and there's a pouch between the uterus and the rectum. Now, the vesico-uterine pouch and the recto-uterine pouch are what we're talking about. So if we look, we see this image, and we see all these organs that I've discussed. The vagina, we see the uterus, we see the ovary, the uterine tubes, and some suspensory ligaments and round ligaments all holding these organs in place. Now, if we look here, we see this peritoneal pouch created as the peritoneum dips down in front of the uterus between it and the bladder, and that is the vesico-uterine pouch. And we also have one behind the uterus, between the uterus and the rectum, and this is the recto-uterine pouch. All of this is just created by that peritoneal membrane folding here as it comes in contact with these organs. And we've also got this overhead view, the superior view of the female pelvic cavity, where you can see the bladder is in front of the uterus, and the uterus is in the back with the uterine tubes and the pair of ovaries suspended above it with that suspensory ligament and the broad ligament holding everything all in place. You also have the ovarian ligament specifically holding the ovaries. Now, the first thing we're going to look at is the paired main female gonads, and these are the ovaries. And these are found on the lateral walls of the pelvic cavity. So each ovary typically only weighs between 6 and 8 grams, and they're about the size of a walnut. Now, these organs appear relatively smooth before puberty, but as a woman matures, they take on a more bumpy appearance due to scar tissue that is left behind when ova are released every month. And these ovaries perform two main functions. They produce ova, and they secrete several hormones. And among these hormones are the estrogens, which include estradiol, estrone, and estriol, with estradiol being the most abundant. And we will use the term estrogens to refer to all of these collectively. And in addition to those estrogens, the ovaries also produce progesterone, inhibin, and relaxin. And we'll talk about some of these a little later. Like other organs, the superficial portion of the ovary is the cortex, and the deeper portion is the medulla. The ovarian cortex is going to be the site of oogenesis, and this is the production of those female sex cells, those gametes. And in females, these gametes are produced inside sac-like structures called follicles, which will develop and mature along with the gametes. The ovarian medulla is a sort of inner region that houses blood vessels, lymphatic vessels, and nerves. And each ovary is held in place by 3 ligaments. You have the broad ligament first, which is a large flat ligament that attaches to the ovaries, the uterine tubes, and the uterus, and connects them to the bony pelvis. Then you have the ovarian ligament, which connects the medial surface of the ovary to the uterus, and then near the attachment of the uterine tube, that's near the attachment of the uterine tube. Finally, you have the suspensory ligament, which connects the lateral surface of the ovary to the pelvic wall. And so we're going to look at this issue. We're going to look at this figure here in just a minute. But you're going to notice that this suspensory ligament, sorry, the suspensory ligament also carries the ovarian artery and the ovarian vein. So let's look at the things we just discussed. We've got the ovary here, and you can see it is sort of bumpy from the scar tissue of releasing ova over the years. And you do have the cortex, which is this outer layer, and then the inner medulla, which houses the arteries and veins. And of course, you can see this is the suspensory ligament connecting the ovary to the lateral pelvic wall. You've got the ovarian ligament hiding behind this image, connecting the medial surface of that ovary to the uterus. And then, of course, you also have the broad ligament, which you can see really well right here. This whole thing is the broad ligament, and it works to connect the ovaries, the uterine tubes, and the uterus, and connects them to the bony pelvis. And we'll look back at this issue. We'll look back at this photo to reference all the rest of these. I just wanted to make sure that you guys got a chance to look at this clearly first. Now, outside of the ovaries, we have the uterine tubes, also called the fallopian tubes or the oviducts, and these form the first portion of the duct system of the female reproductive system. Externally, they're covered by the peritoneum and are supported along their length by part of the broad ligament. Internally, they're lined by smooth muscle and simple columnar epithelial cells with both ciliated and non-ciliated cells. Now, each tube is about 10 centimeters long and extends medially from the ovary to the superior and lateral regions of the uterus. At the proximal end, this uterine tube is going to connect to the uterus in a constricted region called the isthmus. And the distal end of each uterine tube expands and curves around the ovary, forming the ampulla. And this is where the fertilization of an oocyte normally occurs. The ampulla is going to connect to the infundibulum, which is a sort of open funnel-shaped structure. And at the end of the infundibulum, there are these finger-like ciliated projections called fimbriae, and these drape over the ovary and catch an oocyte that is released from an ovary during a process known as ovulation. Now, the uterus, known commonly as the womb, is part of the pathway through which sperm has to travel to reach the uterine tubes. This is also the site of fertilized egg implantation, and it provides protection and nutritional support for a developing conceptus. In addition, the contractions of the uterus are responsible for ejecting a fully developed conceptus known as a fetus during childbirth. If pregnancy does not occur, the uterus is also the source of menstrual flow. Now, the uterus is located in the pelvis, in front of the rectum, and behind the urinary bladder. A hollow, thick-walled, muscular organ approximately the size and shape of an upside-down pear. It weighs between 30 and 40 grams, but it can be larger in women who have previously born children. Much like the ovaries, the uterus is also supported by several ligaments. Inferiorly by the lateral cervical ligaments, which extend from the cervix and the superior vagina to the lateral walls of the pelvis, and posteriorly by the paired uterosacral ligaments, which connect the uterus to the sacrum. In the front, it is also anchored by the round ligaments, which connect the uterus to the anterior body wall. and laterally by the broad ligaments. In addition, they also receive a great deal of support from the pelvic floor muscles. And outside of all that, you have three regions of the uterus. The main portion is the body, and this is the rounded region superior to the entrance of the uterine tubes. You also have the fundus. I'm sorry. This is the rounded region superior to the uterine tubes. You also have the cervix, or the narrow neck, that projects into the vagina inferiorly. Uh, and the body is the location between these two. Uh, the most inferior portion of the cervix, which serves as the entrance into the uterus, is known as the external os, and it is the portion of the cervix that is generally observed during a pelvic examination. There are glands in the mucosa of this cervical canal that secrete mucus that covers the external os that acts like a sort of protective plug. And the wall of the uterus is composed of three layers. There's the perimetrium as the outermost serous layer, which is also an extension of the parietal peritoneum. You have the myometrium, which is the thick middle layer composed of bundles of smooth muscle. This will contract rhythmically during orgasm and during childbirth to expel the fetus from the mother's body, and in some women to a lesser degree during the menstrual cycle. And the innermost endometrium lines the uterine cavity and is a mucous membrane composed of simple columnar epithelial cells on a layer of connective tissue called the lamina propria. And here we have the slide covering those ligaments, the lateral cervical ligaments, the uterosacral ligaments, the round and broad ligaments. And we'll look at that image again here in just a second. And here we can begin to see some of the portions of the uterus. You see we have the fundus, which reaches from here to here, the body here to here, and the cervix at the inferiormost portion. The ligaments holding it, you've got the pair of uterosacral ligaments. You've got the lateral cervical ligament sitting on down here on the bottom. You've also got the round ligament over here. And the layers of the uterus, you can see here, the layers of the wall of the uterus, from deep to superficial, endometrium, myometrium, perimetrium. You also do have the fornix, but I believe we're going to discuss that with the vagina. The fornix is just this region that we talk about as the border between the cervix. I'm sorry, the uterus and the vagina. This cervix region is the base of the uterus. Almost forgot to mention the regions of the uterine tube. Yes, the fallopian tube. We also discussed that. So yes, we have those finger-like projections, the fimbriae. We have this rounded, sort of bulbous area, which is the ampulla, and that's normally where that fertilization site is. This sort of cup that sort of goes around the tip of the ovary, that is the infundibulum, and this region here where the uterine tube meets the cervix, or the uterus, I'm sorry, is the isthmus. Almost forgot to mention those. Now, the vagina itself is the female organ of copulation because it receives the penis and semen during sexual intercourse. Now, it also provides a passageway for the delivery of a fetus and for menstrual flow. The vagina is going to be a thick-walled tube, approximately 8 to 10 centimeters long, that extends from the cervix to the exterior of the body. And it parallels sort of the anterior urethra lying between the urinary bladder and the rectum, with the superior end of the vaginal canal surrounding the external os of the cervix, producing that recess of the vaginal fornix. The wall of the vagina is going to be covered in these transverse ridges or rugae, which stimulate the penis during intercourse. And generally, the lumen of the vagina is quite small, except where it is held open by the cervix and its walls will touch one another. However, the vagina stretches considerably during both intercourse and childbirth. Now, the mucosa of the vagina is a stratified squamous epithelium which allows it to withstand this friction. It has no glands, but it is lubricated by cervical mucus and secretions from the epithelial cells, which increase during sexual excitement. In addition, these epithelial cells will secrete glycogen, which resistant bacteria will break down and allow that to produce ATP and lactic acid. This helps maintain the acidic pH of the normally healthy vagina and helps keep it free of infection. Earlier, we mentioned that the acidic pH of the vagina is also hostile to sperm, and this is one of those reasons why alkaline semen is so important for maintaining sperm health in the female reproductive tract. Now, in most women, the mucosa near the distal vaginal orifice forms an incomplete partition that is often referred to as the hymen. And the hymen is very vascular and can bleed when it ruptures. And it happens in about 50% of women during their first experience with sexual intercourse. But that's not the only cause. It can also very commonly rupture during sports activities, horseback riding, anything that may jostle the pelvis can rupture the hymen. Now we're going to turn our attention to the external female genitalia, and this is the vulva. And these are female reproductive structures that lie outside the vagina. The external genitalia include the mons pubis, the labia majora, the labia minora, the clitoris, and structures that are associated with the vestibule. And colloquially, commonly, the external genitalia are just referred to as the vagina, but that's not really the case. The vagina is located internally and is not really a portion of the external anatomy. Now, the mons pubis is going to be a sort of fatty, rounded area that overlies the pubic symphysis and is covered with hair after puberty. Posterior to the mons pubis are two elongated skin folds. These are called the labia majora, which enclose two thinner skin folds called the labia minora. And enclosed within the labia minora, there is a recess known as the vestibule. And the vestibule contains the urethral orifice and the vaginal orifice and the paraurethral glands, which discharge mucus into the urethra. In addition, you also have the openings of the greater vestibular glands, also called Bartholin's glands, which release small amounts of mucus into the vestibule, helping to lubricate the opening of the vagina during intercourse. Now, anterior to the vestibule, there's the clitoris, which is a small protruding structure composed of erectile tissue. And this corresponds with the corpora cavernosa of the penis and is very important in the female sexual response. Just like in the penis, the erectile tissue of the clitoris becomes engorged with blood and is innervated by many sensory, motor, and autonomic fibers. You also have tactile, pressure, and temperature receptors in abundance here, and these are all very important for sexual stimulation. And if you guys remember the term the perineum, it is that diamond-shaped region between the pubic arch, the coccyx, and the ischial tuberosities. And the tissues of the perineum for the female are going to overlie the muscles of the pelvic outlet, and the posterior ends of the labia majora overlie this central tendon, which is the insertion point for most of the muscles supporting the pelvic floor. The region between the vagina and the anus is called the clinical perineum, And a common procedure during childbirth is doctors will cut a straight incision through the skin and muscle of this area if a tear appears likely. This is a procedure known as an episiotomy, and these are done because straight incisions are much easier to heal and repair than are jagged tears. Uh, there are several degrees of these tears, and none of them are particularly pleasant. Uh, the episiotomy simply makes the repair of this. It's essentially a tear regardless, but the clinical use of the scalpel makes this repair much easier. And so here we see some of those structures. Let's use green. So we see the diamond perineum composed of those boundaries. You have the anus as its sort of posterior boundary, and the clitoris as its superior boundary. Speaking of which, you have the clitoris, you have the labia majora, the labia minora. You also have, you see the vaginal orifice here. You've got periurethral glands on either side of the urethral orifice. You've got the openings here alongside the vaginal orifice of the greater vestibular glands. All of these sort of working to secrete mucus and allow easier flow. You've also got the mons pubis on top, and that appears to be it. Do note that the urethral orifice, the periurethral glands, the vaginal orifice, and the vestibular glands all make up the vestibule. Now, the other external anatomy structure that we need to talk about are the mammary glands. And the mammary glands are technically part of the integumentary system, and they're actually just modified sweat glands. The major biological role here for these glands is to produce milk that nourishes a newborn infant. And so really their only function is when reproduction has already been accomplished. These are present in both sexes, but normally only function in females. Each mammary gland is going to be contained within a rounded, skin-covered breast in the hypodermis region. Superficial to the pectoralis major muscle of the chest, just below the center of each breast, there's going to be an area of pigmented skin called the areola, which surrounds the central protruding nipple through which milk will exit that gland. Inside each mammary gland, there tend to be between 15 and 25 lobes that radiate around and open at the nipple. These lobes are padded and separate from each other by fibrous connective tissue and fat, and they receive support from suspensory ligaments that attach the breast to the underlying muscle fascia and the overlying dermis. And within each lobe, there are smaller units called lobules, which contain some granular alveoli, and this produces milk when a woman is lactating. Contraction of some myoepithelial cells that surround these alveoli propels the milk from the cells toward the nipples. And when milk is being produced, it passes from these alveoli into a series of mammary ducts, which flow into the lactiferous ducts that open to the outside at the nipple. And then just deep to the areola, each lactiferous duct has a dilated region called a lactiferous sinus. And this is where milk will accumulate during nursing. We'll talk about this a little bit more, the process and regulation of lactation in chapter 27. But in non-pregnant women, the glandular structure of the breast is mostly undeveloped, and these alveoli are not present. And so for this reason, breast size is largely due to the amount of adipose tissue in the breast. And the breast also happens to be one of the most common sites of cancer for women. And so here you can see that breakdown of lobe to lobule, lobe to lobule to all the way down. We see it begins to go down to um, mammary duct and then to lactiferous duct, and all of those drain their way toward the nipple and that lactiferous sinus to be held there until the infant is nursing. This table is going to summarize the functions of each of the female reproductive organs, and I've already gone over these, but I'll allow you guys to pause this if you need to and review as needed. But we're going to continue now. Now, as I said, breast cancer is the most common form of of cancer for women, or it's the second most commonest cancer in women after, again, non-melanoma skin cancer, especially in the U.S. About 200,000 cases a year are diagnosed, and a few hundred of which occur in men, but the vast majority is in women. Risk factors tend to include maternal relatives with breast cancer, longer reproductive span, which means an earlier first menstrual cycle coupled with menstruation continuing at a later age. Obesity is a risk factor, no pregnancies or the first pregnancy after the age of 35. The presence of breast cancer genes, especially two particular genes that increase susceptibility to breast cancer, BRCA1 and BRCA2. Unfortunately, for most people, breast cancer is painless until it becomes really advanced and has metastasized. Therefore, early detection is one of the best ways to prevent it from spreading. Monthly self-examinations can locate bumps that may be malignant. Mammograms, which you can see some here. These are x-rays of the tissue of the breast, and these can detect small areas of increased tissue density. And a mammogram can detect very many small malignancies that are not yet palpable in a self-examination. Physicians tend to recommend that women over 50 have a mammogram every 2 years. Any woman with a family history of breast cancer should have regular mammograms before the age of 40. And treatment for breast cancer tends to involve chemotherapy, a lumpectomy, which is surgical removal of the tumor and surrounding tissue, or a mastectomy, which is the complete surgical removal of the breast and possibly the underlying pectoral muscles and some of the axillary lymph nodes. Several chemotherapeutic drugs may decrease the risk of recurrence or the disease progression. But this is a very serious cancer. I myself have a grandmother who had no choice but to resort to a double mastectomy after hers had progressed. But she's still around, knock on wood, and it hasn't returned. Again, knock on wood. Now that we've discussed most of the anatomy, now we're going to cover the physiology of the female reproductive system. And the first thing we're going to cover is oogenesis and how it differs from spermatogenesis. After that, we're going to shift our attention to the ovarian and uterine cycles and how the cyclic fluctuation of hormones tends to control those cycles. Now first, oogenesis. And this is the process of gamete development in females, which produces an ovum, an egg cell. And it differs from spermatogenesis in many ways. For one, oogenesis actually begins before a female infant is born, but then it stops. This process arrests before puberty. And at that time, it will resume and remain active as part of the ovarian cycle until it ends at menopause. And this usually occurs between the ages of 45 and 55. And we're going to look here at the stages of oogenesis. So before birth, these stem cells of females called oogonia undergo a mitotic division before birth during months 2 to 7 of their fetal development. And this means that a female produces all of the oogonia she will ever make or ever have before she has ever even been born. And at about 7 months of fetal development, the total number of oogonia is about 7 million. And this is as high as it's ever going to be, though, because this number rapidly drops as many of them begin to die. The remaining 1 to 2 million oogonia will begin to undergo meiosis 1, at which point these oogonia are now referred to as primary oocytes. And these primary oocytes will proceed as far as prophase 1, at which point the development is arrested until puberty. And during childhood, these primary oocytes stay in prophase 1 and don't develop any further until puberty, at which point rising hormone levels will trigger the beginning of the ovarian cycle. Do note that during childhood, primary oocytes will continue to degenerate, and by the time a girl reaches puberty, the number drops to roughly 300,000. Now, once a person gets to puberty, once a female gets to puberty, there are about 20 to 30 primary oocytes stimulated to continue development every month. And usually, one primary oocyte, or more in some women, will complete meiosis 1 and produce 2 haploid cells that are very different in size. There's a much larger cell and a much smaller cell. The smaller cell is going to be the first polar body, and it contains DNA, but very, very little cytoplasm, and it very often degenerates. The larger cell, called the secondary oocyte, contains DNA and most of the cytoplasm, plus some absorbed extracellular fluid. This extra cytoplasm in the secondary oocyte ensures that if it is fertilized, it will have adequate nutrients for its 4 to 7 day journey toward the uterus. And the large amount of cytoplasm is also the reason why the secondary oocyte has the potential to become an ovum. Now, once we actually, begin and progress through the ovarian cycle, this secondary oocyte will begin meiosis 2. But again, this development is going to be arrested, this time in metaphase 2. If the secondary oocyte is fertilized, it will continue and complete meiosis 2, and it will divide to form an ovum and a second polar body. If fertilization does not occur, the secondary oocyte will remain in metaphase 2, and it will eventually be shed along with the menses. Of a woman's 300,000 primary oocytes, only about 400 or 500 of them will become mature secondary oocytes during her reproductive lifetime. And so here you can see this image that shows the stages of oogenesis after puberty. So once puberty occurs, every month they're going to shed a primary oocyte, and it's going to shed that first polar body, which will degenerate, and the secondary oocyte will continue through the uterine tube. And if it does get fertilized, you see here, if you see it does get fertilized, then it will continue past metaphase 2, and it will become a true ovum, and it will be fertilized here, a fertilized ovum, after it sheds yet a second polar body to get to the proper number of chromosomes. Really quickly look at here at the difference between spermatogenesis and oogenesis. Now, both of them do produce haploid gametes with unique combinations of alleles, right? But the notable differences are here between the two processes. Let's compare them and see why these differences exist. The first key distinction is the number of cells produced. Sperm are continuously produced in high numbers after the onset of puberty, and this high sperm production occurs for two reasons. First, sperm have to reach the secondary oocyte to fertilize it, and to do so, they have to travel through the dangerous female reproductive tract. And I say dangerous or hostile, inhospitable for the sperm. Most will not survive, and so the sperm that enter the reproductive tract, the more sperm that enter this tract, the better the chances of fertilization. Second, sperm cells have to penetrate the secondary oocyte by secreting enzymes. However, one sperm cell by itself cannot produce enough of this enzyme. Hundreds of sperm are needed to secrete their enzymes so that one can make it through. In contrast, the oocyte production is complete before the female is even born. And so from puberty to menopause, she generally will release only one secondary oocyte per month. And this makes sense because there's no need for the female reproductive system to produce multiple secondary oocytes at one time. In fact, it would actually be dangerous to produce that many, as the female system already has a difficult time supporting more than 2 or 3 conceptuses during one pregnancy. And another difference is really the structure of the gametes. As you just read, when a secondary oocyte forms, it's going to receive most of the nutrient-rich cytoplasm, and the extra set of DNA is going to be discarded in a polar body. The nutrients in the cytoplasm help support the developing conceptus until it can receive nutrients from the mother. And this situation differs for a sperm cell. It only needs to deliver genetic material to the developing oocyte. So any excess cytoplasm is going to be removed during spermiogenesis, and that keeps the sperm cell lean and small. You can reference this table and it'll show you the sort of summary of these key differences between spermatogenesis and oogenesis if you need to reference it at any point. We are going to continue, though, through the chapter, so I'll give you just a couple seconds to review this before I move on. All right, moving on. Now, these oocytes, when they're inside of the ovary, they're going to live inside of these structures called ovarian follicles. And these are these blister-like structures in the ovarian cortex that mature along with the oocyte. The first follicles are formed when the female uterus, formed in the female uterus, are called primordial follicles. Each one contains one primary oocyte. And then from childhood through early menopause, primordial follicles progressively mature first to primary follicles, then to secondary follicles. However, most follicles stop maturing and instead die in a process called atresia, during which and the oocyte first dies, followed by the collapse of the follicle. Now, once a female hits puberty, she begins the ovarian cycle, and this is a monthly series of cyclical hormone changes and events controlled by the hypothalamic pituitary gonadal axis, that HPG axis. Under the control of this cycle, each month a group of secondary follicles is going to be stimulated to progress to the next stage of development. This is called the vesicular follicle or the tertiary follicle. Again, most of these secondary follicles atreziate and die, and usually only one remains. Now, we are going to see some the phases of the ovarian cycle here. These are the follicular phase, the ovulation, and the luteal phases. And we'll look at those in just a second. I'm going to give you guys these images to look at first, and then I'll refer back to them after we discuss in depth what occurs in each of these phases. But you've got the follicular phases here, and then eventually we get down to the vesicular phase, and then you have the ovulation phase, in the middle here, and a luteal phase. And again, I'll go in depth on each of these, and I'll pull these images back up after we discuss them in depth. Now, the first of the phases is going to be the follicular phase, and this is the development of these follicles is a process that occurs continuously from childhood to menopause. And during a follicular phase, the follicle grows and develops, and the maturation really tends to follow like this. First, a primordial follicle is a single layer of squamous follicular cells surrounding a primary oocyte. At birth, each ovary has between 1 and 2 million primordial follicles. Excuse me if I confuse primordial and primary. I'll do my best to make sure I say these correctly. Primordial follicles are present at birth at about 1.2 million, and each of them contains a primary oocyte. Eventually, during childhood, many of these primordial follicles begin developing into primary follicles. As this occurs, those follicular cells change shape from flattened to cuboidal, at which point we call them granulosa cells. And then two important structures are going to appear here in these primary follicles: microvilli and thecal cells. Microvilli tend to develop in the oocyte and grow in the surrounding granulosa cells and form a connection. Part of this connection is a glycoprotein-rich area called the zona pellucida, which becomes important if the oocyte is later fertilized. Microvilli also increase the surface area available for those granulosa cells to transfer materials to the growing primary oocyte through gap junctions. And only a small number of these primary follicles will continue development. Eventually, as childhood continues, the primary follicles develop into secondary follicles. The wall of the follicle will thicken, and the deeper granulosa cells secrete follicular fluid. And this forms small pockets and increases the overall size of the follicle. In addition, the granulosa cells grow, enlarge, and stimulate nearby cells in the ovary to form a layer of thecal cells around the follicle. And the granulosa cells produce estrogens from the secretions of the thecal cells. And this primary oocyte is still growing very slowly at this stage. Now, at puberty, due to rising levels of follicle-stimulating hormone and luteinizing hormone, a group of secondary follicles is going to continue maturing. Usually only one follicle, the dominant follicle, completes this process and becomes a vesicular follicle. In a vesicular follicle, smaller pockets of follicular fluid form from a secondary follicle merge and form a single large cavity called the antrum. The primary oocyte and its surrounding capsule of granulosa cells, now known as cumulus cells, project into the antrum. And as the vesicular follicle continues to enlarge, it may reach 15 to 25 millimeters in diameter, and it will create a visible bulge in the surface of the ovary. At this point, the primary oocyte, which was previously suspended in prophase 1, will complete meiosis 1 to form the secondary oocyte and the first polar body. And it is then suspended in metaphase 2, and it will not complete meiosis unless it is fertilized. And keep in mind that the maturation of any one individual oocyte and follicle will take 3 to 4 cycles to complete. So it takes about 90 to 120 days for the dominant follicle to mature to a vesicular follicle with a secondary oocyte. Now, in the ovulation phase, most often just called ovulation, the secondary oocyte and its associated granulosa cells, now called the corona radiata, are going to be released from the ovary. The fimbriae of the uterine tube sweep the ovarian surface, allowing them to catch this ovulated secondary oocyte, and the oocyte is carried then into the uterine tube, where through peristalsis and beating cilia, it manages to move the oocyte toward the uterus. There are non-ciliated cells in the uterine tube that produce a mucus-like secretion, and this keeps the oocyte moist and nourished. Do note that because the ovary is not directly attached to the uterine tube, the fimbriae may not pick up the oocyte, at which point it is released into the peritoneal cavity. Now, after the oocyte is released, the vesicular follicle will collapse and ruptured vessels will bleed into the antrum. The remaining structure is now called a ruptured follicle. Usually only one vesicular follicle is at the peak of maturation when ovulation occurs. However, sometimes more than one vesicular follicle releases a secondary oocyte. And this phenomenon results in those fraternal twins or non-identical twins. And it occurs more commonly in some families, and it also increases in frequency with advancing maternal age. Identical twins are a completely separate phenomenon that results from fertilizing one oocyte with one sperm and then a separation of the dividing cells early in development. Now, the luteal phase is the period in which the remnants of the ruptured follicle can become an endocrine organ called the corpus luteum. And there are two steps to this phase. First, the remaining granulosa cells from the ruptured follicle will enlarge, and along with the thecal cells, form a yellowish colored corpus luteum. And the corpus luteum secretes progesterone and some estrogen. And as we will shortly discuss, progesterone is necessary to maintain a pregnancy. So if the pregnancy does occur, the corpus luteum persists for about 3 months to produce hormones. If pregnancy does not occur, the corpus luteum degenerates in approximately 10 days and stops producing hormones. The second step is when levels of hormones secreted by this corpus luteum begin to decline, macrophages within the ovary invade this corpus luteum and degrade it, while fibroblasts will lay down collagen fibers. This reduces the corpus luteum into a structure called the corpus albicans, which is essentially a whitish knot of scar tissue. And this event marks the end of one ovarian cycle. Now, if you assume the ovarian cycle of 28 days, the follicular phase typically goes from day 1 to day 14, and ovulation will occur on day 14. And then the luteal phase will extend from day 14 to day 28. However, less than a quarter of the women in the world normally have 28-day cycles. Cycles as short as 21 days or as long as 40 days are pretty common. And it's common for the same woman to experience 1 or 2 day fluctuations from one cycle to the next. In these cases, it's the length of the follicular phase that will vary. The luteal phase tends to remain constant. It is almost always 14 days from the time of ovulation, to the end of the cycle. And then bear in mind that at any time from childhood to menopause, there are several follicles in an ovary in various stages of development and decline. This is an ongoing process involving multiple follicles maturing over an extended period of time, rather than just one follicle that matures in 14 days. Now, of course, we see, just as a review, we have a primordial follicle, which consists of a primary oocyte and the follicular cells surrounding it. Now, once that primordial follicle becomes a primary follicle, what we're going to see happen here is this primary oocyte is still the same, but the follicular cells now change their shape. They become cuboidal granulosa cells. In addition to that, we add on those thecal cells and some microvilli on the outside. And Eventually, the primary follicle will become, of course, a secondary follicle. And a little bit more happens here. The primary oocyte that still exists in the center is going to now be surrounded by multiple layers of those granulosa cells. And the granulosa cells are going to begin producing these pockets of follicular fluid. And those are going to be found in these secondary follicles. Once we get to a tertiary or a vesicular follicle, we have the secondary oocyte. So now the primary oocyte has matured to a secondary oocyte. These granulosa cells are still there, and they form now a fluid-filled antrum. And this antrum is where that oocyte is going to be expelled soon. Of course, we still have thecal cells surrounding, and the granulosa cells are still doing their job. Once we get to ovulation, we're going to have that ruptured follicle, and the corona radiata and the ovulated secondary oocyte are going to be released. So they're going out of the follicle. And what happens next is this oocyte travels down hopefully gets picked up by the fimbriae and swept down the uterine tubes. But the follicle itself is going to change, and now it's going to become the corpus luteum. And the corpus luteum is what remains of that follicle, and it works to now become that endocrine organ that secretes progesterone and some estrogen. And then eventually, the corpus luteum will be broken down. It depends on whether this individual is maintaining a pregnancy or not. If they're not maintaining a pregnancy, about 10 days, the macrophages are going to convert the corpus luteum into scar tissue, and it will become the corpus albicans. And all that's left of the corpus luteum is just basically scar tissue, and it no longer secretes hormones. Now, ovarian function regulation does require some fluctuation of hormones from the hypothalamus, the anterior pituitary, and the ovaries themselves. They operate and interact in that negative feedback loop in the same hypothalamic pituitary gonadal axis that operates in males, with the exception of a positive feedback mechanism that then triggers ovulation. Okay, so during a 28-day cycle, levels of hypothalamic, anterior pituitary, and ovarian hormones will fluctuate as follows. So first, the hypothalamus is going to release gonadotropin-releasing hormone. Secondly, that GnRH is going to stimulate the anterior pituitary to release follicle-stimulating hormone and luteinizing hormone. And the follicle-stimulating hormone stimulates those granulosa cells in the follicles that secrete estrogens, and they convert androgens into estrogens, and they secrete inhibin. And the luteinizing hormone stimulates the thecal cells to create those androgens and target granulosa cells. Now, that's what occurs almost in the third tier, because the ovaries are going to be the site. The ovaries are going to be the site, the target organ of follicle-stimulating hormone and luteinizing hormone, with the luteinizing hormone stimulating thecal cells in the follicle to secrete androgens, and those androgens then diffuse through the basement membrane to the granulosa cells. Follicle-stimulating hormone stimulates the granulosa cells in the follicles to convert those androgens into estrogens. And follicle-stimulating hormone also stimulates granulosa cells to secrete inhibin. Now, the estrogens and inhibin produced have some various effects throughout the reproductive system. Estrogens stimulate the dominant follicle to continue developing into a vesicular follicle, and the granulosa cells of this new vesicular follicle continue to produce estrogens in increasing amounts. In most cases, a rising concentration of the target hormone would trigger a negative feedback loop, right? So that means that you might expect more estrogen to cause the anterior pituitary to stop producing luteinizing hormone. But the opposite actually happens. When granulosa cells eventually produce enough estrogen, they exert positive feedback on the anterior pituitary and trigger a huge increase in luteinizing hormone release. This is known as the luteinizing hormone surge, and the LH surge, accompanied with a rise in FSH secretion, triggers ovulation, and the resulting corpus luteum produces additional progesterone, estrogens, and inhibin. Now, follicle-stimulating hormone does stimulate the granulosa cells to secrete inhibin, and along with increasing levels of estrogen, now exerts a negative feedback loop on the hypothalamus and the pituitary. Estrogens will inhibit gonadotropin-releasing hormone and luteinizing hormone secretion, as well as inhibiting follicle-stimulating hormone secretion. And so this negative feedback loop prevents other primary follicles from beginning to develop too early. And if fertilization occurs, the progesterone from the corpus luteum will inhibit gonadotropin release and will continue to do this. If fertilization does not occur, however, the corpus luteum will degenerate into the corpus albicans, and estrogen, progesterone, and inhibin levels drop. With ovarian hormones no longer inhibiting secretion of gonadotropin-releasing hormone, levels rise, the gonadotropin-releasing hormone levels rise, and the cycle will begin again. And so as you guys can see, this ovarian cycle requires lots of hormones working together at the right times, exerting the right type of feedback in order to function properly. Imbalance in any part of this cycle can interfere with ovulation and cause infertility. And we'll talk about that when we look at the clinical A&P aspect of female infertility. Now for women, remember, infertility is an inability to conceive a pregnancy after 1 year of unprotected sex. And a most common reason for female infertility tends to be a problem with ovulation. And remember, without ovulation, there's no secondary oocytes to fertilize. And there are several possible causes. PCOS is one, polycystic ovarian syndrome, and this is a condition that results in excessive androgens, and it decreases the production of estrogen. And you also have primary ovarian insufficiency, and this occurs when a woman's ovaries stop working as normal before the age of 40, and this is not the same thing as early menopause. You also have some lifestyle factors like cigarette smoking, being severely underweight, poor diet, stress, and even excessive athletic training, all of which can decrease the production of estrogen. And then you also have obesity, which increases the production of estrogen to the point that they block luteinizing hormone and secretion by and follicle-stimulating hormone secretion by negative feedback. Infertility can also be related to problems outside of the ovary. Blockages of the uterine tubes because of pelvic inflammatory disease, endometriosis, or uterine fibroids. These are non-cancerous tissue clumps and muscle on the internal walls of the uterus. And all of these can lead to difficulty with conceiving. Now, treatment for infertility depends on the cause. There are medications, including synthetic gonadotropins, that may stimulate ovulation. You have abdominal surgery that may be necessary to clear blocked uterine tubes or to remove any endometriosis or fibroids. And if there's no other treatment that is successful, IVF, in vitro fertilization, is an option. It's an expensive option, but it is there. In this procedure, what happens is the doctors are able to harvest oocytes and sperm from the mother and father or from donors, and they are fertilized in a laboratory, and then the fertilized zygote is then implanted into the mother's uterus. Now, estrogens and, to a lesser degree, progesterone also stimulate female secondary sexual characteristic development. And these effects include the maturation of the sex organs, development of the external genitalia, and maintenance of anatomical features that are unique to adult females, like breast development, fat accumulation around the hips and the thighs. And in addition to these, progesterone is responsible for maintaining a pregnancy if fertilization has occurred. And we will talk about that in chapter 27. But estrogens do have far-reaching effects on other tissues, that many of which are beneficial. Estrogens can help reduce the breakdown of bone by inhibiting these osteoclasts, and this can help prevent osteoporosis. They also have protective effects on the cardiovascular system. Estrogens can increase the level of HDLs, which are quote unquote the good cholesterol in blood, while lowering the levels of LDLs, and these are the quote unquote bad cholesterol. However, not all estrogen's effects on the CV system are always beneficial. They can promote blood coagulation, and this accounts for the increased risk of women developing clots who are taking estrogen-containing medications like oral contraceptives. And here's that HPG axis where you see the hypothalamus releases gonadotropin-releasing hormone, which acts on the anterior pituitary to release luteinizing hormone and follicle-stimulating hormone, where ovaries then secrete androgens in response to luteinizing hormone, and the ovaries themselves then convert these androgens that they've created into estrogens, and they secrete the estrogens and inhibin in response to follicle-stimulating hormone. Then you have the effects there, the estrogen stimulating one dominant follicle to mature to a tertiary follicle or a vesicular follicle, and the new vesicular follicle will now produce large amounts of estrogens, triggering that luteinizing hormone surge. And the luteinizing hormone surge and follicle stimulating hormone together trigger that ovulation. And so you can see here the luteinizing hormone is that positive feedback. But if there is a negative feedback, that can also happen. Estrogens do tend to inhibit luteinizing hormone secretion, and estrogens and inhibin both work together to decrease follicle-stimulating hormone. So these are the same hormones can have either a positive feedback or a negative feedback, where estrogens also tend to lower the gonadotropin-releasing hormone secretion. So it all depends. If this new vesicular follicle that has been created produces enough estrogen, it will trigger that luteinizing hormone surge and trigger ovulation. Now we have the uterine cycle, or the menstrual cycle, and this is a series of cyclical changes that the uterine endometrium goes through each month, responding to fluctuating levels of ovarian hormones. And these uterine changes tend to be coordinated with levels of estrogen and progesterone that are released during the ovarian cycle phases. So let's look at the structures of the endometrium first that are changed by these hormone levels. So first, you need to understand that the endometrium has two main layers, or strata. And the first one is the stratum functionalis, and this is the functional layer. This undergoes the cyclic changes in response to ovarian hormones. It detaches from the uterine wall and is shed as a discharge of between 35 and 50 milliliters of blood and other materials from the vagina approximately once per month during menstruation. You then have a thinner, deeper stratum basalis, or a basal layer, and this does not thicken in response to the ovarian hormones, but it forms a new stratum functionalis after menstruation ends. Now, there are numerous endometrial or uterine glands that tend to change in length as endometrial thickness changes. The main vascular supply of the uterus tends to come from uterine arteries that arise from the internal iliac arteries in the pelvis. They branch several times and eventually form what is called the spiral arteries of the stratum functionalis. Now, we're going to look at the three phases of the uterine cycle, and so for simplicity, we're going to assume that it's a 28-day cycle. Now, Days 1 through 5 are the menstrual phase. During the menstrual phase, the uterus sheds the stratum functionalis, resulting in menstruation. After that, you have the proliferative or pre-ovulatory phase, and during the proliferative phase, there is a new stratum functionalis developing with the endometrial glands and the spiral arteries and veins. And as this new layer thickens or proliferates, its endometrial glands enlarge and its spiral arteries and veins increase in number. Cervical mucus here is thick and sticky until just before ovulation, when it begins to thin and that's in order to facilitate the passage of sperm into the uterus. And at the end of the proliferative phase, around day 14, ovulation occurs. So after ovulation, you have the secretory phase or the post-ovulatory phase. And this is regardless of the normal length of a woman's cycle. This is going to be a 14-day cycle. This is going to be a 14-day phase. During the secretory phase, the spiral arteries convert the stratum functionalis to secretory mucosa, and endometrial glands will secrete a nutritious, glycogen-rich fluid called uterine milk into the uterine cavity in order to sustain the conceptus. If pregnancy does not occur, the cells of the stratum functionalis die, and on day 28, the menstrual phase begins again. If pregnancy does occur, the secretory phase continues, and the uterus will continue to develop. This image really well illustrates the thickness changes of the stratum functionalis as the uterine phase, the uterine cycle progresses. Days 1 through 5, you see, are the menstrual phase, and you see this breakdown that occurs in the stratum functionalis, and it is sloughed off as blood. And again, during proliferative phase, you see it begins to build itself back up, and eventually we get to the ovulation, and after ovulation, you see right up to this point here, we get to peak thickness. We get to this maximum thickness where you have endometrial glands producing mucus or uterine milk. You have the spiral veins and arteries giving blood flow to this tissue. And if pregnancy doesn't occur here, well, then after this point, the stratum functionalis begins to break down again, and it is again going to be released as blood and other tissue. If pregnancy does occur, then this thickening of the uterine wall will continue through the entire pregnancy. Now, uterine function regulation also requires fluctuating hormones from the hypothalamus, pituitary, and ovaries. Again, we're going to assume a 28-day cycle, and we're going to look at the changes that occur during this uterine cycle. So, to simplify this, I'm going to let you guys look at these graphs while I talk about them. Now, one graph shows the changing levels of gonadotropins during the phases of the uterine cycle, right? And another shows the changing levels of ovarian hormones. You can see those, the uterine cycle on top, the changing levels of ovarian hormones on the bottom. As you can see, at the beginning of the menstrual phase, follicle-stimulating hormone and luteinizing hormone levels begin to rise. Ovarian hormones, however, are at their lowest normal levels until day 5, at which point growing ovarian follicles begin to produce more estrogens. As the proliferative phase begins, rising levels of estrogens cause a new stratum functionalis to generate, and it triggers endometrial cells to synthesize progesterone receptors. High levels of estrogens trigger releasing of more FSH and LH, and their levels peak around day 14. This triggers ovulation. At the start of the secretory phase, the level of progesterone from the corpus luteum begins to rise while the amount of estrogen secreted falls. And The high progesterone level in combination with falling levels of estrogens inhibit the anterior pituitary, which, as you can see up top, it leads to low amounts of luteinizing hormone and follicle stimulating hormone. And this progesterone that is created also stimulates the continuing development of the stratum functionalis during the secretory phase. Now, if the ovulated oocyte is not fertilized, the corpus luteum degenerates toward the end of the secretory phase and the progesterone levels fall. Without progesterone, the stratum functionalis layer loses its blood supply and breaks down, triggering the beginning of a new menstrual cycle. If fertilization does take place, the outer layer of the developing conceptus begins to secrete a luteinizing-like hormone called human chorionic gonadotropin, HCG, and this keeps the corpus luteum from degenerating and the progesterone levels high. HCG is unique to the developing conceptus, and that makes it useful as a target compound for those home pregnancy tests. So those sticks that you pee on, those are measuring the levels of HCG in your urine. Now, this is a table that summarizes all of the major reproductive hormones in both males and females. And I've gone over these and what they all do and what secretes them and what their target sources are. But I'll let you guys look at this and pause if you need to review. But we're going to continue on and we're going to look at some test yourself questions right now. Sorry, I lied. We have 2 more modules to cover before the test yourself questions. So first we're going to look at the female sexual response. And this is similar to male sexual response in most respects. During sexual excitement, the vaginal mucosa, the vestibule, and the breasts engorge with blood. The clitoris and the nipples tend to become erect, and the increased activity of the vaginal mucosa and the vestibular glands will lubricate the vestibule. And for the most part, these events are similar to the erection phase in men. Tactile and psychological stimuli mediated by the autonomic pathways promote sexual excitement. However, as in males, orgasm tends to refer to the period during which women experience intense feelings of pleasure, but unlike in males, there is no ejaculation that takes place. The uterus does exhibit peristaltic waves of contraction, and the cervix pushes down somewhat into the vagina. And if semen is present, these actions tend to draw semen further into the reproductive tract. But the female orgasm is not required for conception. Females do not experience a refractory period, so they actually may have multiple orgasms during a single sexual experience. And the female libido or sex drive may be related to an androgen called dehydroepiandrosterone, or DHEA, which is produced by the adrenal cortex in women. Androgens and estrogens both appear to influence sexual behavior because of their interactions with the hypothalamus, and in addition to these, many women experience variations in libido according to their monthly fluctuations of estrogens and progesterone. Now, as we've already talked about, estrogen and progesterone levels increase dramatically at puberty and decline during menopause. So let's look at these 2 periods and the physiological changes that accompany them. So for most girls, puberty begins between 9 and 11. And this is when secretions of estrogen and progesterone increase from the ovaries. Before puberty, there's a low level of gonadotropin-releasing hormone from the hypothalamus, keeping luteinizing hormone and FSH levels low. This, in turn, results in low levels of estrogens and progesterone. At puberty, the hypothalamus becomes much less sensitive to inhibition by estrogens and progesterone, and so gonadotropin-releasing hormone level rises. GnRH stimulates the HPG axis, and blood, estrogens, and progesterone levels rise, resulting in the appearance of female secondary sexual characteristics. Now, for girls, the first sign of puberty tends to be budding breasts, and this is followed by the development of female secondary sex characteristics, those features that are associated with identifying someone as female and are induced in non-reproductive organs by the female hormones, especially estrogens. These characteristics include an appearance of pubic and axillary hair, an increase in the overall amount of adipose tissue in the subcutaneous layer, additional deposits in the breast and around the hips and thighs, increased secretions of sebaceous glands. Oilier skin tends to result in acne, and there's also skeletal changes. There can be increased height and a widening of the pelvis. And approximately 2 years after the onset of puberty, a woman will experience her first episode of menstrual bleeding called menarche. And perhaps because of the physical toll exerted by pregnancy and the female body, menarche and the accompanying cyclical events will not occur unless a woman has at least 15 to 17% body fat. And adult menstruation will completely cease if body fat drops too low. A hormone that is created by adipocytes called leptin stimulates gonadotropin secretion. And so for this reason, if leptin levels lower because body fat is too low, gonadotropin levels decrease as well, directly affecting the HPG axis. This is why you'll hear often about gymnasts, especially gymnasts, not having menstrual periods. And this is because their body fat percentage is too low. After puberty, reproductive cycles will continue regularly until an individual hits their 40s or 50s, at which point they become increasingly irregular. Eventually, the cycle will stop completely, and from the time of onset of irregular menstrual cycles to their complete cessation, typically a period of about 5 years, this is called female climacteric, and it is often referred to as it's just the period of female climacteric. When menstruation has not taken place for at least a year, menopause has occurred. And it takes place because the number of primary follicles left that are able to respond to follicle stimulating hormone and luteinizing hormone is too low. And this is especially true because after approximately 30 years of ovarian cycles, and also because of the atresia process in which immature follicles degenerate, these follicles that remain in the ovaries become less responsive, and so less estrogen and less progesterone are secreted. And as a result, ovulation does not occur, and the blood concentration of estrogens largely drops. And although many women continue to synthesize some estrogen especially from the adrenal glands, secretions of FSH and luteinizing hormone from the pituitary are no longer inhibited, so these hormones may be continuously released for some time. Now, I've already discussed that. Now, the lower concentration of estrogens and progesterone tend to change the female secondary sexual characteristics. The breasts, vagina, uterus, and uterine tubes may shrink, and the pubic and axillary hair may thin. Oftentimes, bone density will decrease, which leads to osteoporosis, and the skin may become thinner. Some women also experience these unpleasant vasomotor signs, including sensations of heat called hot flashes. And a hot flash can last up to 5 minutes, and it may be accompanied by chills or sweating. These symptoms may result from those changes in the rhythmic secretion of gonadotropin releasing hormone by the hypothalamus in response to decline in concentrations of sex hormones. Women also tend to experience migraine headaches, backaches, fatigue, and mood swings during menopause. And some women may experience these symptoms before the age of 45. This is called early menopause. And if it occurs before 40, it is premature menopause. Early or premature menopause can happen for several reasons: chemotherapy or radiation for cancer, um, ovarian removal or uterus removal, autoimmune diseases may cause it, and in some cases, there's a genetic case. Women with family histories of early menopause are more likely to experience early menopause. Now we can look at some of these test yourself questions. So, which of these can be fertilized? All right. So, which of these is possible to be fertilized? It's a secondary oocyte that's fertilized, and then it develops, once it's fertilized, into an ovum. Assuming a 28-day ovarian cycle, on what day should ovulation occur? What day should ovulation occur? It's day 14. Remember, day 14 tends to be the ovulation, regardless of which the post-ovulation phase tends to be 14 days. So if this was a 30-day cycle, then ovulation would take place on day 16. Now, when menstruation has ceased for at least 1 year, what process has occurred? So menstruation hasn't happened for at least 1 year. That's female climacteric or menopause. Now let's continue on through the chapter. We'll talk a little bit about birth control now. All right, now birth control or contraception really refers to any procedure or device that is intended to prevent pregnancy. And so we're going to look at some common methods of contraception here. Now, the first ones we're going to talk about are behavioral methods, and these can be abstinence or withdrawal. And abstinence can be the avoidance of intercourse, and this is the only 100% reliable method of avoiding pregnancy. There's also periodic abstinence called the rhythm method, at which point a person will avoid intercourse near the time of their partner's ovulation. The rhythm, or they will avoid intercourse during their ovulation. The rhythm method has a high failure rate because it is really often difficult to predict the exact date of ovulation. And intercourse has to be avoided for at least 7 days before and 2 days after ovulation. So there's really no surviving sperm and fertile oocytes in the reproductive tract at the same time. So that's a 9-day period that has to be exactly correct. There's also the withdrawal method. You may have heard it called the pull-out method. This is coitus interruptus, and it involves withdrawing the penis before ejaculation. This also has a high failure rate because it's difficult to time withdrawal accurately because sperm can be present in the pre-ejaculatory fluid. In addition, sperm can be ejaculated anywhere on the vulva and potentially enter the female reproductive tract. Now, we've also got barrier methods of birth control that prevent the sperm from moving beyond the vagina. These methods include condoms, diaphragms, cervical caps, and the sponge. And these are all temporary methods, and the most common one is probably the condom. And most are made out of synthetic materials like latex, or some are made from animal membranes if the person has a latex allergy. Most commonly now, those are replaced with nitrile, I believe, as lamb intestine tends to not be very preferred. Male condoms worn on the penis are the most common type of condom in use. There are female condoms that are inserted into the vagina that include a flexible ring on the outside and a flexible ring on the inside that covers the cervix, and an outer ring that covers the external genitalia. In addition to reducing the risk of pregnancy, synthetic and latex condoms also lower the risk of STI sexually transmitted infections. You also have diaphragms or cervical caps that are placed inside the vagina, and what they do is they cover the cervix, and it blocks sperm from entering through. Now, both of these barriers require a prescription and a physical exam for proper fit. There is a similar form of birth control that requires no fitting, and this is called the sponge, and it is a foam disc that is inserted before intercourse that covers the cervix. And there are many, many of these barrier methods, and most of them, especially the diaphragm, cervical cap, and sponge, are made more effective when using a chemical spermicide, which kills or damages sperm cells that it comes in contact with. Spermicides can be available without a prescription, and many are purchased as foams, creams, or jellies. Here we can see some of those temporary methods. We got the male condom here and the female condom here. This would be a diaphragm cap. Diaphragm. You have a cervical cap here and the sponge. And over here you have some packets of spermicide. Then you have hormonal methods like the oral contraceptive or birth control pills, which you see here on the far left. These contain synthetic estrogens and progesterone, which artificially raise the levels and have that negative feedback loop on the release of follicle-stimulating hormone and luteinizing hormone. Without proper levels of FSH and LH, follicle maturation doesn't occur, and so neither does ovulation. In addition, they can interfere with the buildup of the endometrial lining that is necessary for implantation. And a side benefit is that oral contraceptives often reduce the amount of monthly bleeding during menstruation because they reduce the thickness of that endometrial lining. In fact, some reduce the number of menstrual cycles to only about 4 per year. And they are very effective at preventing pregnancy if they're taken as prescribed. They can cause some side effects. Some of them are relatively minor. There's nausea, fluid retention, and breast tenderness. And others can be potentially more severe. The risk of serious side effects like cardiovascular or liver problems increases as the women age out over 35, especially if those women smoke or have histories of high blood pressure or bleeding disorders. There is an alternative to the combined estrogen-progesterone pill. This is called the mini pill, which only contains progesterone. And a high level of progesterone thickens that cervical mucus, making it difficult for sperm to reach the egg. And this makes it the mini pill slightly less effective than the combined pill. There are some hormonal alternatives to the daily pill, including vaginal rings, which you can see here in the middle left. The vaginal ring contains estrogen and progesterone, and they're worn for about 3 weeks, or 3 weeks or so, typically between menstrual cycles. You also have skin patches, you see middle right, and that contains estrogen and progesterone, and those patches are going to be replaced every week. We also have intramuscular injections of progesterone every 3 months, and you can see that on the right. I don't know how to say that. I'll just indicate it here. This one. And then you also have thin rods, and this is becoming much more common of progesterone containing rods. These are implanted under the skin of the arm and remain in the body for approximately 3 years. So all of these are hormonal methods. They just differ in how they're delivered and, of course, in the length of time for which they're in the body. You could also opt for an IUD, an intrauterine device, and this is a small T-shaped device made of plastic and copper. It has to be placed into position by a health provider where it will remain for about 10 years. This prevents pregnancy by affecting how a fertilized ovum is able to implant into the uterine wall. Additionally, copper is released when it's inside the womb, and this spreads to the uterine tubes where it manages to poison sperm and the oocyte. Now, an intrauterine system is a small T-shaped device similar to an IUD, but it is only made of plastic and releases instead a small amount of progesterone each day that prevents pregnancy. And an IUS can remain in the uterus for approximately 5 years. And here you can see the wings of that IUD and the copper coil that wraps around the base of it. Now, there are permanent methods. Everything we've talked about so far has been temporary, but there are permanent methods, and they're often referred to as sterilization because they render the individual sterile or incapable of reproduction. And most of these techniques require a surgical procedure, although they can sometimes be reversed with an additional surgery, and the second surgery can be successful less than about half the time. Therefore, permanent methods are best for people who do not wish to have children at any point in the future. There is male sterilization accomplished by a surgical procedure called a vasectomy, and the physician then will cut through and either ligate or cauterize the ends of the vas deferens, and this prevents sperm from leaving the man's body with the semen during ejaculation. After a vasectomy, sperm are still produced, but they degenerate and are destroyed by phagocytosis. Semen is also still produced because the vas deferens is cut below the area where the accessory structures secrete the other components of semen. In addition, the blood vessels remain unaffected and the blood testosterone level remains normal. And so for this reason, a vasectomy technically has no effect on sexual desire or performance. Since some sperm remain in the vas deferens, unprotected intercourse should be postponed until all sperm have been phagocytized, which can take up to 12 weeks. You've also got tubal ligation, and this is when this is quote unquote getting the tubes tied in women. And during this procedure, a surgeon makes an insertion into the wall of the body cavity, cutting through the uterine tubes, and they will either cauterize or ligate their ends. And this can prevent an oocyte from passing through the uterine tubes, and the sperm that may have been able to reach the oocyte now cannot. There are non-surgical permanent methods of birth control called tubal implants. These small metal springs are going to be placed in each uterine tube, not requiring incisions in the abdomen. And over time, what happens is scar tissue grows around the implant and will permanently block the tubes. 3 months after the procedure, there's typically a follow-up X-ray taken of the uterine tubes, which have been completely filled with contrast dye to see if they're blocked. Unfortunately, no perfect form of birth control exists. And so we're going to look at a table here that'll show the failure rates of any available contraceptive methods. First, the procedures I mentioned. So yes, we see on top, we see a vasectomy where the vas deferens has been pulled through, and eventually the surgeon will either cauterize and burn those ends shut, seal them shut, or they simply tie them shut and they ligate them, preventing sperm from traveling anywhere. The same is true in a tubal ligation, at which point the uterine tubes are tied or burned and sealed shut. So here we've got this table that shows the methods and the failure rates. Now, the rate of failure, if it is used consistently and correctly, you see that the only perfect one is complete and total abstinence. We get down to as low as 0.1 per 100 0.1% with the skin patch, the vaginal contraceptive ring. A vasectomy gets down to 0.1. Tubal ligation gets down to 0.5%. Male and female condoms, 2%. So there is no perfect method except complete abstinence. Take from that what you will. So let's look at some test yourself questions. A couple wants to have sexual intercourse, but they don't want to use a behavioral method because they know it has a high risk of pregnancy. What could they use instead? They could use condoms. Condoms are one of the most effective non-behavioral temporary methods. Let's say a female wants to take a hormonal contraceptive that only contains progesterone. What is her best option out of these? Hormonal contraceptive that only contains progesterone. Those are going to be those intramuscular injections of the Depo-Provera shot. Especially, those are the ones that I'm not going to test you guys specifically on brand names, but just remember that intramuscular injections tend to be progesterone only. Now, a sexually transmitted infection, that's what we're going to focus on now, also called a sexually transmitted disease or a venereal disease, is an infectious disease spread through sexual contact. One of the most important causes of reproductive orders, STIs often cause infertility and deformities and can even result in death of a fetus. You guys should have already discussed HIV and AIDS when you talked about the lymphatic system. This one's going to present several of the most common STIs, distinguishing between those that are caused by bacteria and parasites and those that are caused by viruses. Now, the first ones we're going to talk about are caused by disease-causing bacteria and parasites. Both types of pathogens are foreign cells that invade the tissues, creating an inflammatory reaction. The most common bacterial and parasitic STIs are chlamydia, gonorrhea, syphilis, and trichomoniasis. The first one we're going to talk about is chlamydia. It is a common STI caused by the bacterium Chlamydia trachomatis. Even though this is easily treated with antibiotics, about 3 million chlamydial infections occur every year, even in the US. And this is because chlamydia tends to produce no symptoms in most people. And if symptoms do occur, they may not appear until several weeks after exposure. And the most commonly include painful urination, pain in the pelvic region and testes, and vaginal or penile discharge. Newborns can develop this infection in the birth canal, and as a result, they can develop respiratory infections and a form of conjunctivitis called trachoma, which can actually lead to blindness. In women, untreated chlamydia can spread into the uterus and the uterine tubes, causing PID, pelvic inflammatory disease, which scars the uterine tubes, and that can prevent fertilization. You've also got gonorrhea, commonly called the clap. This is caused by Neisseria gonorrhoeae. Gonorrhea infects about almost 1 million people every year. It is treatable with antibiotics, but there are resistant strains of the bacteria becoming more prevalent. Although some men have no symptoms, most exhibit painful urination and penile discharge, which can range from white to yellow to green. For most women, you're asymptomatic, but painful urination and vaginal bleeding may occur. As with chlamydia, untreated gonorrhea can lead to PID and blindness in newborns. Gonorrhea and chlamydia can often actually occur together. So that's a double whammy that you got to be careful for. Again, these are easily treated by antibiotics if they're not resistant. You've also got syphilis caused by the spiral-shaped Treponema pallidum. About 50,000 individuals become syphilitic each year, and the bacteria will incubate for about 6 weeks and then create a small, painless lesion called a chancre, at which point the disease is now transmissible to other people via contact with the chancre. In males, the chancre usually forms on the penis, but in females, it can actually form inside the vagina and go undetected. The chancre generally heals within 6 weeks, and the disease seems to have run its course. However, now the second stage of the disease will appear when a pink skin rash appears all over the body with fever and joint pain and hair loss even. Symptoms can again subside, but this time within about 3 months. If the disease has not been cured, it will enter a latent stage. Symptoms of syphilis can come and go for years, although the immune system may eventually kill the bacteria. It is also possible for the disease to progress into tertiary syphilis, which produces destructive lesions in the brain and very heavily damages cardiovascular organs, bones, and joints. And this is all damage that can easily be fatal. Now, antibiotics can treat the infection, but it cannot repair the damage done. Infected newborns may exhibit no symptoms, but can have a huge health impacts like impaired vision and hearing if they're not treated with antibiotics. You've also got trichomoniasis, and this is caused by a parasite, a protozoan parasite called Trichomonas vaginalis. And about 3 to 4 million people have the infection, which is easily cured with antibiotics. But trichomoniasis can cause itching, burning, or redness, and in women, it creates a whitish to greenish vaginal discharge that has a very distinct, very strong odor. However, with many other STIs, most individuals tend to exhibit no symptoms. If an infection occurs during pregnancy, this can lead to premature birth and low birth weight. Now, unlike bacterial and parasitic infections, viral infections are going to be caused by viruses, taking over cellular organelles responsible for protein synthesis, using them to make copies of themselves. These new viral particles are going to be released from the cell and go on to infect others. The common STIs we're going to talk about are HPV, human papillomavirus, and herpes simplex 2. Now, HPV is caused by, genital warts is the disease caused by human papillomavirus. It's one of the most common STIs in the United States, with almost 80 million people currently infected with HPV and 14 million new infections every year. Genital warts associated with HPV can occur in just under 500,000 people a year. Warts appearing on the penis, perineum, or anus in males, and on the cervix, vaginal wall, perineum, or anus in females. And the most common risk to newborns is a wart in the throat called a recurrent respiratory papillomatosis. And this rare condition results from the mother having genital warts during her late pregnancy. And these are treated with a cryosurgery, a laser surgery, or interferon, a cytokine released by infected cells, helping to combat these intracellular pathogens. And the worst part about HPV is that it's a huge cause of cervical cancer. Many of the strains that cause genital warts don't lead to cancer, but a vaccine against HPV can prevent most common disease-causing strains, including those that cause the 70% of cervical cancers. Most cases of HPV are going to induce penile, vulvar, vaginal, and anal cancers, and about 90% of genital warts. Now, there is no medication to treat HPV after it's been contracted, which just further underlies the importance of preventing it. Now, you've also got genital herpes, which are caused typically by the herpes simplex virus number 2 or type 2. About 750,000 people are infected every year, and many are unaware that they harbor the virus. This disease causes tiny blisters that can be extremely painful on the external genitalia of both sexes, sometimes on the thighs and buttocks as well. This virus is most easily transmitted when the blisters occur and if there is direct skin-to-skin contact. However, a person is contagious even during the dormant stage, which can last weeks to years. And herpes infections can be passed to a fetus, resulting in neonatal herpes, a potentially fatal infection. Genital herpes can also increase the risk of HIV infections and some cancers, with the only treatment being antiviral medications, which manage to shorten or sometimes prevent outbreaks. And daily use of these antiviral medications can reduce the risk of transmission to sexual partners. Now, cervical cancer occurs most often in women between the ages of 30 and 50, particularly those with a history of STIs, cervical inflammation, or multiple pregnancies. And it is frequently caused by HPV, a sexually transmitted infection. Now, cervical cancer used to be a leading cause of cancer death for women in the US, but in the past few decades, the number of cases and the number of deaths have lowered dramatically and are projected to decrease further as the HPV vaccine becomes more widespread. The decline is largely due to the Pap smear test, and this detects precancerous cells in early stage cancers before symptoms are noticeable. These Pap smears are super easy to do. All they do is they scrape some loose cells, and I know scrape and cervix do not go together, but it's a little bit of pain to see if any of these precancerous cells show up, or if there's any abnormal development called dysplasia, and that can warrant further investigation, including a visual examination of the cervix or even a biopsy. If any cancerous cells are detected, surgical removal of the tumor or even a complete hysterectomy, which is removal of the uterus, may be required. Additionally, there's radiation therapy or chemotherapy if it's needed. We're going to have some test yourself questions, and then that's going to be it for chapter 26. All right, now which of these STIs is not caused by a bacteria? Which one is not bacterial? Herpes. Herpes is not caused by a bacterium. It's caused by herpes simplex type 2 virus. You got a little case study here. Let's say a female patient comes in. She has a greenish white discharge from her vagina that has a strong odor. She also has itching and burning of her genitals. What STI does this person have? Most likely she has trichomoniasis. I'm telling you that strong odor is the key. It is my old med micro professor used to always tell you could walk by a room and tell if a person has trich. This is all we have for this week. We'll see you guys in the next one. We talk about chapter 27. We're going to talk more about development